Vision Education Class 1 Eye Health, presented by Dr. Rajiv Ramchandran.
Hello, everyone. My name is Dr. Rajiv Ramchandran, and I'm a retina specialist and ophthalmologist. That's an eye doctor at the Flom Eye Institute at the University of Rochester. There, I serve as an associate professor of ophthalmology. I teach their various trainees, residents, and our fellow. And I also engage in population health, trying to get to people before they become patients and promote wellness and health in terms of eye and vision care. So with that, I would like to talk to today about the causes of vision loss and what you should know about your eyes and your vision. And we're going to go through a few slides here to talk about eye anatomy. We're going to talk about some diseases that commonly affect the eye and also speak about how they affect your vision and what sort of treatments or management plans there are for them. Now, I know many of you have vision loss, often severe, and have tried various treatments and unfortunately at this time may not be able to improve your vision. So many of you are taking a course on building resilience training and understanding how to manage your vision at its current level, and also potentially prepare for further vision loss if your disease is progressive. So just wanted to introduce myself and say that many of you have a much greater understanding of what it is to live with these diseases than I do. I can just explain to you some of the science and some of the background about the diseases. So hopefully that will give you some more knowledge and insight into how the eye works and how your eye may be affected by the various conditions that you have. For those of you who are attending the Rebuild Resilience Training course, you will definitely get to hear more lectures on managing your vision and your current state of ability to get around and to be more independent or to maintain your independence from the further lectures. And you have a lot to teach me, I'm sure, if I do get to interact with you about what it is to live with vision loss and what it is to manage with vision that is less than what normal usually would be or what you used to have. So with that, I want to start and talk a little bit about the eye. So the eye is like a camera. It basically receives light. It is a sensory organ. So the light comes in through the front of the eye, through the cornea, which is the window of the eye. It's a clear structure. And then it filters in the eye through the hole in the iris, the color part of the eye called the pupil. It's focused by the lens. Many of you have had cataract surgery, so that's when the lens gets cloudy and you remove the lens and put an artificial lens in its place. And this lens basically focuses light on the back of the eye, the retina. In between, there's jelly called a vitreous jelly that can condense as you age, and that can cause floaters. The retina itself is divided into various structures. There's the macula, the central part of the retina where your sharpest vision is. And the center of the macula is called the fovea, where the most clear vision is obtained when light hits this region. Now, all these signals that are captured, light signals that are captured by the retina, are converted into electrochemical signal and transported to the brain via the optic nerve. And so that's a very important structure. And the retina is supplied by a rich blood supply, not only the blood supply that feeds the retinal structure itself, but also the structure underneath the retina called the choroid. And that's a very vascular, very blood-rich structure that allows for nutrients to get into the deeper parts of the retina and feed the cells that actually receive light and transform it into a electrochemical signal called photoreceptors. Here's another diagram of how the eye looks, and just in keeping of how it works, the light enters then the cornea, then enters through the pupil, gets focused by the lens and also the cornea to the macula, the back part of the eye, the fovea being the center of the macula, and the retina being the structure that is basically an extension of your brain that receives light, translates into a electrochemical signal that's transported to the optic nerve, sends it to the brain. It's the brain that actually does the seeing. The brain interprets the image interprets the light, interprets the signal into an image, and that's basically how you see. It also interprets motion and various other aspects of the signals that it gets. So your brain is very much dedicated to processing vision. Almost over 60% of the brain is dedicated to processing vision. So vision is one of the most developed senses, if not the most developed senses in the human being. So how do we assess vision? So vision is assessed through various ways. We assess it through visual acuity, or the ability to distinguish details, which measures the clarity of vision, the sharpness of vision. Contrast sensitivity, which is the ability to see low contrast patterns, such as faces, and images or patterns on various backgrounds, depending upon the shades of these backgrounds. So this also influences quality of vision. The visual field, or it's the area of vision. So you can have loss of central vision, peripheral vision, or you can have blind spots in your vision. So visual field is another way that people measure vision or the quality of vision. Fixation and tracking, the ability to focus on an object and follow it over a course of time is important in reading. Sometimes if you miss where you are in a page, and that can be due to fixation issues. Glare recovery, so when you're coming in from bright light to darkness or darkness to bright light, this ability to recover from exposure to sunlight or the glare of headlights. That's also a way that people measure vision. Stereo acuity, the importance of seeing depth. You have to have two well-functioning eyes so that you can gauge how far away two structures are relative from each other, so that when you're threading a needle, you want to know how far your needle is from your thread, and if you're able to align the two. So that's what stereo acuity helps you. It's also 3D, when you want to see 3D images. It's also important to have two good functioning eyes in order to do that. Color vision is something that is affected in many people, often men, but it's also something that happens to diminish when you get older because of things like cataract or macular degeneration or just aging changes in the eye itself. The colors don't get as bright, and they get more dimmer and unsaturated. So that's also something else that happens. It also happens in various eye diseases, especially those that affect the optic nerve or retina. So one of the aspects we can talk about in vision is just blurring. And so you can have a blur over the entire field, or the image can be distorted, and it can vary with degrees of intensity or various aspects of contrast sensitivity. And you get complaints of blurring, haze, glare, poor contrast, and you need more light to read sometimes, or the light may be too bright and causing glare in what you're seeing. And some of the most common causes of blur is refractive error, or the inability for your cornea and lens to focus light right on the retina, which is what their job is. So those who are emetropic or have normal sight, their lens and cornea basically focus the lens right on the retina with or without glasses. If you need glasses, then that's corrected. And those who need glasses to see at distance are called myopic, and that's because the light is focused in front of the retina, and it's not focused in the back of the retina. But with glasses, that focus point changes, and it does get focused in the back of the retina. Hyperopia are folks who have the focus of the image behind the retina. So it's a virtual image, and then glasses help to bring it forward. Usually this happens in children, and if you don't need glasses as a child, you sometimes are able to compensate for your hyperopia. But when you get older, you need reading glasses sooner because it's harder for you to see up close because the lens over time gets hard, the muscles around the lens get weak, and so the lens can't be shifting its position in order to see up close and far away. So it just basically um, um, doesn't relax as, doesn't constrict as much. The fibers that are around the muscles, the zonules, don't constrict as much, and the muscles don't allow you to accommodate or allow for focusing up in the air. So, in fact, the treatment to correct this blur is often just a pair of glasses. And I know many of you with significant vision loss, glasses may not be helpful. But for a majority of people out there, glasses are the mainstay of correcting vision loss. And in fact, they've shown a study where a third of nursing home residents were having poor vision just due to needing a pair of glasses. So that's still a very important thing to help people is just making sure they have the right pair of glasses. In fact, when you did give new pair of glasses to these nursing home residents, their better vision related to better quality of life, less difficulty with activities, daily living, and they had fewer depression symptoms as well. So let's go through the various parts of the eye and talk about how damage to each of them affects vision and how science has allowed for some treatments and some correction of some of the issues that occur at these various regions of the eye. The first region we're going to talk about is the cornea. So cornea defects can cause blur. Some common corneal defects are keratoconus, or when your cornea looks more like a football shape or pointed rather than a round, nice basketball shape, which is shown in the first picture here. You can get dystrophies where there are deposits on the cornea, so the cornea is clouding, and so these are inherited dystrophies. Infections, which can cause scarring or opacity of the cornea, so that doesn't allow for light to penetrate the cornea. And then you can also get scarring and edema or swelling of the cornea, and that can also cause vision loss because it doesn't allow the light to enter the cornea. It's not clear anymore, so it's not allowing light to enter through the cornea. So these are corrections are usually optical. So you get contact lenses. You have procedures to smooth the surface of the cornea with lasers often. You can get transplant cornea. So here's an example in the bottom picture here of a person with a corneal transplant. So when you hear about donation of the eyes, often what is being donated is the cornea. The rest of it often may go to research and do various studies on, but the one thing that gets transplanted in humans is part of the cornea, so that the structure is fairly well transplanted because it doesn't have any blood vessels, and so the immune rejection of these transplants are very low compared to other transplants, other organ transplants in the body because of that. So just a picture here of the cornea with various sutures that have kept the donor cornea in place in a recipient receiving a corneal transplant. So something else that can cause general blur is dry eye. So you can see here how the reflection of light in the top right picture here is not very clear. There's a little graininess, and so that's showing you a dry tear film or lack of tear film there. And you can get scratchiness, sandiness in the eyes, worse usually in the windy and dry weather. You get burning, itching, something like it feels like in your eye, and sometimes you get glandular dysfunction. So here in the bottom left, there are some pictures of some plugged glands, and that can also affect the vision over time because if you have plugged glands, you're not producing the right amount of tears or consistency of tears, and that can cause trouble and cause a lot of discomfort as well as some blurry vision. So doctor may notice decreased tears, blocked glands, inflamed lids, redness, and you can actually have more blinking or even excessive tearing because the tears are too watery and they're not staying around long enough, so your body just keeps producing more of inefficient tears. So in these cases, you can use artificial tears, humidifiers. You can block the tear drainage sites with silicone implants there that can be put in the office. If you have oil dysfunction or the glands are not functioning well, you can have a warm compress. You can do eyelid cleaning with some baby shampoo, a couple of drops of that in warm water, and a clean washcloth to soak the eyelids and eyelashes to help open up the glands. Sometimes you need oral antibiotics if there is some infection or even inflammation, because some of the antibiotics are also anti-inflammatory, and that can also help decrease the impediment for good tear production. So moving beyond the cornea, the surface of the eye, we move to the lens of the eye. And as I was saying earlier, that cataract is the most common cause of blindness in the world. It's also a common cause of blur. So here you can see an image of that's blurred out, and that's often just because of having a cataract. So I know many of you with more significant vision loss, probably cataract has already been addressed, and it's not as much of an issue, but especially in the developing world where access to care is limited, cataract still seems to be or is the largest problem that's causing blindness. So there's a lens that's outside of your eye. It's usually clear, but as you get older, due to UV light, due to aging, if you have diabetes, to high sugar, the lens can get cloudy, and this cloudiness of the lens is called a cataract. So cataract refers to waterfall. You can't see past a raging waterfall like Niagara Falls. The same thing, you can't see behind this cataract. And here's a picture of a very brownish gray lens, and that's a sign that this person has a pretty dense cataract there in the lower right. So cataract surgery is the most common operating surgery in the United States, and cataracts will increase to 30 million people by this year, and it's a leading cause of curable blindness in the world, and worldwide it's still a big issue. In America, though, we have pretty good access. So we have access to cataract surgery, which is done now using lasers to help break up the lens, and also ultrasound devices to remove the individual pieces of the lens. And so, and after that's done, implantable lens is put in. So the ultrasound is used to break up the lens, then the lens pieces are taken out, and then an implant is put into the eye, and that implant helps to focus the light. And those usually stay clear. Sometimes you get a film that develops over the implant and has to be lasered over time. But generally, once you have a cataract surgery, you don't develop another one. So moving beyond the lens, let's talk about the optic nerve now. So the optic nerve, again, is the cable that goes from the eye to the brain. And this helps move the signal from the retina to the central nervous system. And in the brain is where those signals are converted into an image. So visual field defects can occur when the optic nerve is damaged. They can be peripheral, or loss of the outer part of vision, or they can be paracentral, loss of the middle section of vision in various spots, and this can cause blindness. The peripheral field defects, first, the glaucoma is often caused, and glaucoma is progressive. It affects the peripheral visual field usually first, and then the central, but sometimes it can affect the paracentral visual field, and this is due to damage to the optic nerve, thought to be due to pressure in the eye that is higher than what the nerve can handle. So often it can be what's considered normal for somebody. You can still have a pressure in the quote-unquote normal range, but you still can be developing glaucoma because for you that pressure is too high. Or you can have pressure in the not normal range, or outside of the normal range, and it could be high, usually in the upper 20s, 30s, 40s, and those pressures chronically over time, often days to weeks, months, can lead to vision loss. So glaucoma is dying of the optic nerve fibers related to pressure, fluid production in the eye, often more common in African American individuals, and when there's a family history, usually seen after age 40, although there are a lot of forms of congenital or glaucoma that develops in kids or was there present at birth. It's irreversible damage when it happens. So on the left-hand side, you see a normal-looking optic nerve. On the right-hand side, you look at a larger cupping there, a large yellow internal spot there where there's no tissue, and less of the outer rim there in that eye. So glaucoma is found in over 2 million people, and now is gone to 3 million, and it's treated with drops, lasers, and surgery. So the surgery is there to make a little bleb or a drainage implant can be put in. So these are the two middle pictures here where there's a little bleb in the conjunctiva, or a drain was made inside the eye to help with the fluid outflow, or they actually put a drain into the eye itself, and that tube there basically helps to take out fluid more rapidly in the eye, so that helps to maintain the pressure. Lasers have also been used to help regulate the pressure in the office. So these are the ways and forms of pressure management in the eye, because the eye pressure that forms the eyeball, it's too high for the optic nerve. In order to reduce it, these procedures are needed. Other causes of visual field defects include neurologic causes, anything that affects the central nervous system. Remember, I said that the brain is where the images are formed, that the electrochemical signals from the retina are basically translated and by structures in the brain. And if you damage any of these structures, including the optic nerve, you get field loss. Of course, you damage the optic nerve totally, you lose vision in that one eye supplied by the optic nerve. If you get lesions in the brain, by that time, the fibers from both the left and right eyes have crossed, and so you get problems in one side of your visual field. So if you affect the right side, you get a problem in the left side of the visual field. If you affect the left side of the brain, you get the issue in the right side of the visual field. So the treatments for neurologic peripheral field defects is really to treat the cause, and usually systemic cause. So you're going to treat the stroke. I'm going to do rehab, occupational therapy. You want to prevent further strokes from happening, and often now there's vision retraining, using virtual reality to retrain one's vision. And a lot of this has shown some success in getting people's peripheral vision back, or utilizing areas of their brain that were not being used before for vision as much, and recruiting them to be used for vision. So that retraining is very important. Optic nerve diseases, just those that lead to atrophy or lack of oxygen that causes atrophy or damaged optic nerve, which is called ischemia, can lead to defects in the paracentral region, or it can also lead to defects of the whole visual field, or at least partial visual field as well. So in the right-hand side there, you can see a picture of a person with an optic nerve atrophy. It's very pale, and the cup to disc is rather large in this eye. So the treatments of paracentral field defects is really to treat the underlying cause and to limit vision loss. So you have to find and treat systemic diseases based on lab tests often. Those who have giant cell arteritis, the C-reactive protein, and the ESR, the erythrocyte sedimentation rate, those two markers may be high. And if it is, you may have this what's called giant cell retinitis, or inflammation of your temporal artery, and that artery which runs just near your ear, that also does supply part of the retina and optic nerve, and when it's damaged, you get lack of blood flow. When this vessel is damaged or due to inflammation, you get lack of blood flow to the eye, and that can cause blindness, leading to peripheral vision loss. In between the optic nerve and the front of the eye is the vitreous humor, and this is the jelly of the eye. It's like egg white in consistency. When you broke open an egg, it's very sticky and attached to the retina. When it does separate due to aging and it condenses more liquid, you may see floaters, and it also may pull on the retina and cause you to have flashing lights at that time when it does stimulate the retina by pulling on it. In normal aging, the vitreous jelly here becomes more liquid, and it does peel off from the retina over time. And the floaters are the condensations of the vitreous, and the flashes are tugging of jelly on the retina. Increased number of either of these flash of floaters concerning that you may have developed enough traction to cause a tear in the retina, and that may lead to blindness. So moving on to the retina then, which is the back layer of the eye, the back wall, lining the front of the back wall, or the most interior part of the back wall. The retina is nerve tissue, it's an extension of the brain, and it's like film in a camera. When you have increased flashes and floaters, it may be associated with retinal tear detachment, because the tear itself occurs when the jelly pulls on the retina, usually, if it's not due to trauma or other causes. And when the jelly separating can pull on a very adherent spot and cause that area to tear, and that can cause a release of pigment and blood, which is seen as increased floaters, increased dots in your vision all of a sudden. So you get hundreds of dots in your vision all of a sudden. That's a concerning sign that a tear has happened, and that tear can become a detached retina. So both of these things, like tear and retinal detachment, have to be repaired pretty immediately, and early diagnosis is key. 15 of 100,000 people per year have retinal detachment generally in the population, and so it's not very common, but it's not uncommon either. And so it's something to be vigilant for if you have the signs of increased flashes, floaters, or dense veil or shadow over your vision, as is being shown by the picture here with a wine bottle that the patient is, or the person is kind of losing vision on their nasal field here. So the increased flashes and floaters, you should definitely see your eye doctor. And early diagnosis is key to find these tears so that you can laser them, which is what's shown in the picture in the right-left corner, right-left lower corner. Or if you have a detached retina, the retina has come off the back of the eye, so wallpaper peels off the back of the wall, or peels off the wall, you may need a gas bubble to tampen on the retina back, and then laser to help secure the retina back. Often at this time you have to go to the operating room and also remove the jelly that's in the eye to help the retina stabilize and be reattached. So here's a picture of a retinal break in the retina, in the periphery, and then retinal detachment. So you can see the bullous detachment just above the optic nerve there. The treatments for retinal breaks and detachments, there's really surgery. There's a vitrectomy, or removal of the jelly from the eye, and then we have gas injections. We do lasers to help seal the hole, a scleral buckle or a band to help secure the retina in place by shortening the scleral wall of the eye so that it can hug the retina that was previously attached. And this, of course, scleral buckle and intraocular surgeries, and in the operating room. So this is a way to fix that. And if you don't treat retinal detachment right away, before it affects the macula or the center of the retina, then you're maybe worse off, because you're high risk for the detachment to continue to spread and to involve the whole retina. And when it affects the macula, the center of the retina, you can lose vision permanently, and that's a problem there. So really, we like to get people treated before they start having significant vision loss from this. And if they do, then the urgency may be slightly less, but indeed, it is something that we do pride ourselves in taking good care of folks who have any eye issues, and try to get them timely care in this sense to get them well. Another thing that happens to retina for folks who have diabetes is diabetic retinopathy. It's actually the leading cause of blindness in the working age population, and it manifests often as a silent disease. So you can have significant diabetic retinopathy but not have any vision issues. When you do have vision issues, it's often patchy and you're missing pieces, or it's a diffuse vision loss where you see a lot of floaters or blood cells, because a blood vessel may have broken and caused more bleeding in the eye. So again, it's a diabetic retinopathy is the leading cause of blindness in the working age population. Over 4 million people have it, and the retina is the only part of the body where one can examine these fine blood vessels with small capillaries. And what is happening to the retina is happening to the rest of the body as well. So it's important to understand, how your retina is doing in terms of any bleeding or any abnormal blood vessels or swelling of the retina, because all these things indicate that some damage is going on with the blood vessels due to the high sugar, high blood pressure, and high cholesterol that is associated with having diabetes or metabolic syndrome. So the two consequences for diabetic retinopathy that can affect the eye are macular edema, or swelling of the retina from leakage of central blood vessels that affect the fovea, the center of the macula, which is the area of sharpest vision. The person can definitely have significant vision loss. And then you can have something called proliferative retinopathy, which is abnormal new blood vessels or neovascularization. And these develop due to poor blood flow in areas of ischemia or lack of oxygenation. And so your body is just trying to deliver oxygen to areas where there is poor perfusion or poor blood flow, and then these new abnormal blood vessels develop that are just inefficient in delivering oxygen and leak and bleed, and that becomes very problematic. So we inject a lot, we do laser to help calm the eye down and to help the fluid that's leaking reabsorb and have less fluid from leaking from the microaneurysms or the outpocketings or the dilations of the vessels, the small capillary vessels that can cause this. And then there's something called proliferative retinopathy, which is the other way that you can lose vision along with macular edema, and that's development of abnormal blood vessels that fibrose and scar and can pull on the retina and cause fractional detachment, as seen in the right lower hand picture here. This is a pretty bad fractional detachment that was not repairable, and this patient just basically lost all vision in his left eye. So it was a pretty bad disease, basically, from what normal looks like. So what causes diabetic retinopathy? Well, the body can't take in glucose or sugar into cells, and over time the glucose accumulates in the blood vessels and causes toxic changes to blood vessels. It causes glycosylation of these blood vessels. So before you had a different mix in the extracellular matrix and different perfusion status of the retina, but with diabetes you get damage to the blood vessels, so your perfusion status worsens and you get more ischemia, so your blood flow is worse. And so it's very important to control your blood sugar, because if you're not well controlled, you get these abnormal blood vessels and you have to lose more and more tissue like peripheral retina. You may have some issues with swelling, as I said, in the eye, or abnormal blood vessels develop because of the high sugar and damage to the blood vessels, causing lack of oxygenation, delivery of good oxygen to the tissue of the retina, which is still constantly seeing, is processing light, and that can lead to further damage in the eye. And again, it's important to control your blood sugar to help manage the diabetes. So the treatment in diabetes, of course, is control your blood pressure, sugar, and cholesterol levels. See your eye doctor at least yearly, an annual eye exam to look for retinopathy. Now, there's new technologies, such as cameras, and often primary care offices are screening for retinopathy. They don't give a complete exam, but at least it's a screening test to make sure that you don't have immediate or urgent retinopathy that needs immediate referral. And if you don't regularly follow up, you may end up at a point where needing surgery or being blind forever because there's no intervention that can help you. So it's very important, if you have diabetes, to see your eye doctor at least every year, to stay in touch with them. And if you're doing the camera-based evaluation or screening with cameras in your primary care office, it's still important to connect with an eye doctor, because that screening, it's not checking for all eye conditions, and those with diabetes are higher risk for other eye conditions, including glaucoma, need for glasses, having had cataract surgery, in addition to retinopathy that we have. Age-related macular degeneration is another issue that affects the retina in the back of the eye, and this is the leading cause of blindness in the older adult population, in the age over 55. It involves central vision loss. So you lose the area of the macula, that's the disease, and that's responsible for the center part of the sharpest area of the center vision, where reading, seeing faces, driving, all that, relates to having good vision centrally, and macular degeneration affects this. So right now, it's about 2 million people in the United States. This is dry and wet form, and most common cause of permanent blindness in the United States after age 55, and it's from the wet form of disease, or the form where there's new blood vessels kind of developing. So there's two forms, like we talked about here: wet, or the abnormal blood vessels that develop behind the retina or in the retina and cause bleeding and cause distortion of the photoreceptors and damage to the anatomy of the retina, which leads to blindness. Or the dry form, where there's deposits called drusen. It can be atrophy or loss of tissue over time, which can lead to vision loss. But in the case of dry, the vision loss is much slower. Only 10% of the population with dry disease has vision loss, but 85% of folks with macular degeneration or age-related macular degeneration has this type of vision loss. And age-related macular degeneration is really defined as people who have this type of pathology over age 55, and that's why it's age-related. The wet form about 15% of the population have this, but over 90% of vision loss is attributed to the wet form because it is more aggressive, and the bleeding and leaking of fluid causes more disruption to photoreceptors, and it causes vision loss that way. Also leads to further atrophy, despite in many cases our treatment. So there are two types. The dry AMD is a slow progression. There's no cure or treatments for it, although they're developing stem cell therapy and other to reverse the change from dry AMD, and also treatments to help arrest it that are injectable in the eye as well. Then there's the wet AMD form, where it's quicker progression, and there are medications to help arrest it. These are the anti-vascular and endothelial growth factor medicines that have been developed. These are antibodies to these specific chemical targets in the eye that are produced in the setting of these diseases, not only macular degeneration, but also age-related macular degeneration, but also in diabetic retinopathy, and help to control that production of factors that are causing new blood vessels to develop and also dilate and leak. So age-related macular degeneration destroys the macula. You can see that the dry type here on your lower left-hand side with drusen, or these aging deposits there that are disrupting the layer underneath the retina. And then there's this massive bleed here in the left-hand picture showing that there would be damage to the central photoreceptors with their sharpest vision, and can really take away the central vision in a person, even despite multiple treatment. So those people who have dry form macular degeneration to a moderate level, to a certain level, they were found to be protected in a study from developing the wet form over time, over 5 years, and that risk reduction was 25%. So instead of having a 40% risk of developing wet macular degeneration at 5 years, by 5 years they had a 30% chance of reduction by taking this pill, AREDS2 formula, or AREDS2 formula, one pill twice a day. Now, the caution with this is that although you're trying to prevent going from dry to wet, the beta carotene in the original AREDS formula did show association with higher rates of cancers and lung cancer, those who smoked. So it's important that, if you're a smoker, that you don't take the beta carotene component, and you stick with the lutein zeaxanthin component. That's an AREDS2. AREDS2 doesn't have the beta carotene anymore. And so AREDS2 is probably the best bet for you, because that lutein zeaxanthin is very important. And those also who are not smokers, they benefit AREDS2 too, because lutein zeaxanthin or carotenoids or micronutrients, they're found in the retina, and these have been found very effective to help treat consequences of having macular degeneration, or even helping to arrest macular degeneration before it gets worse, the dry type before it gets worse. So that's very important. In fact, taking a rich diet in carotenoids has also been shown to help those who have wet macular degeneration when they're receiving the injections of the anti-VEGF into the eye. It helps their recovery too. So nutrition is still tied to good eye health in these cases. So the studies that looked at the injections of the medicines then include Avastin, Lucentis, Eylea. These are some of the brand names for them. It's been shown to be very effective. The randomized controlled trial that's done over a decade and a half ago shows that in 95% of people, vision was stabilized, and about 30 or 40% of people, vision improved, and monthly injections may be needed for 2 years to achieve these results, as that's what the study did. In practice, you do extend and the treatments as the eye is stable, so we can get them 3 or 4 months. You get people who are 3 or 4 months from their last injection, and then we watch them for another 5 or 6 months. So after every monthly injections, we go to like 6 weeks, 2 months, 2.5 months, 3 months, and so on, so that we follow folks at an extended period of time when they're doing well after these injections. They can have less injections and less complications from injections, because sometimes you get infection, bleeding, tear in the retina. The cataract, if you have one, can form a little further. So all those things can happen in these cases. Another issue with the retina is damage to blood vessels. Now, remember, the retina is rich with blood vessels, and it's the only place in the body where you can directly see blood vessels, look in the eye. And so things that affect blood vessels like hypertension, diabetes, embolus can all affect blood vessels found in the eye. and controlling your hypertension, managing your diabetes well is important. Anti-VEGF agents can help with bleeding and swelling from damaged blood vessels, but unfortunately doesn't repair the blood vessels themselves, so that where the body has to heal that and repair what the damage is done. There are also laser treatments to help decrease the swelling around where the blood vessel has been damaged, and also decrease the ischemic drive, or drive of demand, higher demand for oxygen in areas where the oxygen delivery is poor due to damage for blood vessels. So that helps to limit the amount of vascular endothelial growth factor that's developing, and that causes the blood, VEGF causes the blood vessels to become leaky and bleed, and also causes abnormal development or abnormal growth of the blood vessels. So, encouraging one to keep systemically healthy with good management of the blood pressure and diabetes if they have it is very, very important. Other causes of paracentral defects in blurred vision include vitreous traction or vitreomacular traction, where you have pulling on the retina. So this pulling can cause a little hole to form, as in this lower left-hand picture on the OCT, which is a scan that takes the center thickness of the retina, shows there. So it's a macular hole picture on the top, and then the bottom you can see that a macular hole on OCT scan. This is not the same patient. These are different patients, but you can get the idea that there's a hole there and there's a hole here in the center, and that has to be surgically repaired. You can also get an epiretinal membrane or scar tissue over the retina, which is shown here. And about 15% of people over age 85 have an epiretinal membrane over the retina, and often need surgery because they see wavy lines or the letters look cortically distorted to them. So removing this membrane helps retina to settle further and basically helps to clear up some vision. Now you may have, even the patient with the surgery may have some wrinkles in their vision or some distortion of vision. So you have to be very careful on how you counsel people and what you can offer, because the retina may still be not straight and not flat after surgery because of the wrinkling of the retina from the membrane. So treatments of all this include, for the vitreous traction and the epiretinal membrane, include observation. You can watch it if it's not very significant. Vitrectomy, or actually removing the jelly in the eye, which is what this picture is showing here to the left, to the right, and the operating room surgery to peel the membranes. So that's also something that is done, and that I do too, to help people see better by flattening the retina down and curing the undulations that need to be treated with retinal surgery. Inherited retinal diseases is another class of vision issues. It's called peripheral vision loss, and that can lead to then down to central vision loss, or can sectoral, or just a wedge that's missing. And usually starts in the young adulthood or in youth, and it's progressive over time. You start losing your peripheral vision, then you lose your central vision. It occurs in 1 to 2,000 people, and this form that affects as many people is called retinitis pigmentosa, and this peripheral vision loss occurs first. There's also macular dystrophies, which is corrected by gradual loss of vision, and also color vision loss of color sensitivity to testing. So that's another important metric for that. The origin of retinal pigmentosa and inherited retinal diseases have to do with genetic issues. So they have this rhodopsin gene, and it has a mutation. So you can't convert the light signals into electrochemical signals for some classes of your pigmentary cells. And if most of them can't do this, you start losing your vision over time, lost your peripheral vision, and it can be very traumatic and distressing to somebody. But preparation with planning and training is very important over time. And I've seen people who develop this in their older adulthood, who develop inherited retinal disease, that manifests in their older adult life. And it's something still to consider. Like, not only been living it for a long time, you can also develop some non-genetic aspects of this over time. If you are of childbearing age and you have retinitis pigmentosa, having genetic counseling and discussion how certain types of retinitis pigmentosa inherited, and how certain retinal degenerations are inherited is very important. And we're actually having a pediatric ophthalmologist join us, Dr. Andrew Levine, and he has expertise in ocular genetics, and he'll bring that to the Eye Center, the Fallon Eye Institute, and that will be really good for us so that we can help educate people and and patients more about this aspect of their eye. So retinitis pigmentosa, again, affects the peripheral vision. As you can see here, this is the normal retina on your right-hand side, and left-hand side, there's these gray spots and black spots here. That's just the degeneration in the peripheral retina, and the central retina stays okay until the more end-stage part of the disease. We start losing the peripheral vision and visual field over time. Now there's artificial retinas being developed. This one we used to implant here when a few of our doctors, before one left and one unfortunately passed on, were implanting in the eye. This has to do with an electrode that's implanted for folks who have retinitis pigmentosa. So you can only have one diagnosed retinitis pigmentosa, and it has to be very advanced. And they put these electrodes in the eye, and you have a video camera that sends what your visual field looks like. It's sent to this electrode, and the signals are then generated, where those signals are transmitted through the intact nerve endings of the eye. So you have to have an intact optic nerve, and those signals then go to the brain, and it's processed into image. Now the image isn't like what you and I see. Really, it's just shadows right now. You can make outlines of big letters and lines. And so that's basically, you know, what you're seeing right now is the difference between black and white, and edges and shadows. And it's great for somebody who can just basically see light. You flip the switch on, they see light. You flip the switch off, they see dark, and that's all they're seeing. So they can't see any patterns or any more details. And so this kind of contraption, it takes a video of your environment and translates it into a visual signal for you, is a very important aspect of the research that's being done at the Flom Institute and elsewhere. So some effects of vision loss, I talked about the anatomy from the front of the eye to the back of the eye, and talked about the various diseases. Vision loss is functional impairment of your daily activities, and I know you all who have vision loss are experiencing this, so it's very important that you do discuss what your experiences have been, and share that with others, and share with your doctors too, because as a physician, I don't often know what my patients are going through, but I try to relate. But I haven't experienced it myself, and so it's important to have more understanding of what the patient experience is. This can lead to social isolation. If you don't have good vision, you can't participate in social activities, or be mobile, because maybe you can't drive anymore. You can't get to these events, especially in Rochester, where public transportation may be more limited, or in the suburbs especially. You can get risk for physical and mental health problems. Get depression, anxiety, mental health issues. The causes of vision loss may be systemic, like hypertension or diabetes. And so worsening hypertension or diabetes can cause you to have problems in other parts of the body. If those with vision loss are generally undereducated or less employed, there's increased cost to society by having it happen. We talked about driving, and there's also increased risk of falls and hospitalizations, because your visual system is very important for maintaining good balance and be able to move around and be moving around safely. It's just about driving. For a commercial driver's license, you have to have 20/40 or better in each eye. And it's just unrestricted license, you have to have 20/40 or better in one eye. So at least one eye has to see at what a normal person sees at 40 feet, they would have to come up and see at 20 feet. So that's kind of what 20/40 means. Restricted driver's license is daylight hours only. You have to have 20/70 vision or better in one eye, and have a continuous horizontal field of 140 degrees. So if you have a missing piece in the vision, like a big dense visual field loss in the middle of the eye, you may have trouble. Or if you have a constricted field, narrow field with peripheral vision loss, you also may not be qualified to have a driver's license in New York. And you have to have decent acuity. At 20/70 still classified as a low vision, but for daytime driving, it's sufficient, at least in one eye. That's what. Falls late in life, vision and hearing issues are part of that. You have other issues that can cause you to fall as well, but this is part of it. And so it's very important that you get your vision as best correct as you can, so you don't fall. Vision loss and falls are due to decreased visual acuity or sharpness, glare, alter problems with depth, as we talked about, lack of stereo acuity, decreased night vision, loss of peripheral visual field as well, because you don't know exactly where you're going in your environment. So glaucoma and things like cataract can also cause this. Those with profound vision loss, some of you may have this, is just, lost a lot of vision and you can just see shapes and objects maybe even at times in an eye. Sometimes you see things that aren't there. And this occurs with very significant vision loss, like a phantom limb syndrome. You get this phantom eye syndrome where cells that process the visual signals in the brain are firing without receiving input from the eye. So your brain really wants to see, but the eye is not seeing as well as it did, and not the input of signals like it had before isn't there. And so your brain is just creating images, creating figures and things like that aren't there, but it can be very nerve-wracking. So these are called form visual hallucinations. They're not delusions because they're real. You have normal cognition, you get patterns, flowers, people, and if you realize they're not real, you blink through them, you look past the image, and you move eyes back and forth, you may be able to overcome this phenomenon. And this can be a source of anxiety too, and it's named after a person named Charles Bonnet. So this is a little summary of eye disease and your eye health and your eye anatomy. We talked a little bit about the various causes of eye diseases, some inherited, some vascular, some related to other bodily diseases like hypertension and diabetes, and having high risk for stroke. Talked about issues with the cornea and the lens, which can be more easily corrected with transplantation or replacement, as in case of cataract where you have a lens implant. But the retina and optic nerve still don't have good treatments to replace the tissue that's damaged. In fact, they don't have any treatments really in that regard. There's some early work with stem cell therapy being done for the retinal issues, and and you could have genetic issues, and there is some gene therapy going on in young kids for a condition called Leber's disease. But and folks who are affected with advanced disease and into adulthood, the mainstay is just monitoring and counseling for those who have retinopathy or retinitis pigmentosa. There are a special class of people, as those who have very profound vision loss, for that may be benefited by these artificial retina models that are being developed, where they implant chips into electrodes into the eye, basically in a chip wafer form, and then have a process where they take a video in the environment and broadcast that into the eye and allow the brain to at least see some images, and which helps people who are basically just seeing light and dark to actually see objects and to get around and navigate a little bit more. But for those people, who all these things are not helpful for and the treatments aren't there, there's still hope. There's still using visual rehabilitation to maximize your potential of the low vision you have. The ABVI, the Association for the Blind and Visually Impaired, partner with Goodwill, they prepare and empower people who are blind and visually impaired to be self-sufficient and contribute to their families and communities. So those even with people with vision loss can still be excellent and productive citizens in our country, and APVI is a great resource for this. They have various therapies and programs. In fact, this rebuild course where this lecture is being made for is one of the great ones to help to build resilience and confidence and ability to take on the challenges that you may face from having low vision. So while we can't help and treat everybody at this point and get them back to where they were seeing, we can make good efforts in making progress in this area, and science is advancing. But for those people with still having a poor vision, there may be aids and tools that can help maximize your vision potential to help you enjoy life and help you to stay positive and have good resilience and overcoming any challenges that are in your way. I hope you enjoyed my lecture, and thank you so much for listening. Again, my name is Dr. Rajiv Ramchandran. I'm a retina specialist and ophthalmologist at the Flama Institute at the University of Rochester. And I thank you again for your information. If you do have any questions, our phone number is 585-273-3937. Thank you once again, and it was a pleasure talking to you.